All right. So this is Carla. She's a nurse practitioner. So just tell me a little bit about yourself.
Well, I have been a nurse since 1999. Actually started my medical career as a x-ray tech. It's my first stint in the medical world. And I went back and finished my BSN, and straight out of nursing school I did some externships. Well, I guess they were externships back then. They didn't really call them that, but so one of the first things I did was cardiac in Cleveland Clinic, and I worked on a driveline unit. So I got a significant interest in cardiac and cardiac surgery, and then I decided to go into the OR and spent many years in the OR. Then became a first assistant and specialized in vascular, thoracic, and cardiac, into ortho. I'm not sure how those all twine, but that's kind of what I did. And back then, we were able to become clinical nurse specialists by experience, physician training, and getting the med exec committees to sign you off on certain tasks. So the Open Heart Group actually pulled me out and asked if I would be willing to take over their CNS role, which I did for many years. And that's kind of what prompted me to decide to go back and get my NP, was because, you know, I could do certain things, and even though I knew clinically I was capable of doing the other things, I didn't have what I needed to back that up from the education standpoint. So I did go back in 2012. I started my adult acute care NP program and finished in 2015, and continued to work in the outpatient cardiac and acute side of cardiac care. And then I actually took over the wound center back then, and we used to do vascular evaluations down here, and I saw wound patients then, and that's what I'm doing again. So presently, that's what I do now. So we do complex wound healing, debridements, a lot of clinical evaluation, diagnostic testing, you know, just intermediate intervention here, some suturing, but so just basic debridement, complex wound therapy, skin grafts, those type of things.
That's very cool. So that pretty much answered the second question of your position now in their specialty.
Correct.
So right now in healthcare, do you see the APN's influence in the healthcare?
You know, I think there's a lot more that goes into that, because the fact of the matter is, yes, without a doubt. And one way I think that advanced practice providers have influenced healthcare today is, in part, we have, I think, certainly been influential in closing that gap to access of care, which has kind of been huge. In our area, I feel like maybe we don't see it quite as much, even though I think by statistics we have a lower level of patient to primary provider ratio, but we do have a lot of NPs in the area, and I think that helps dramatically increase people's access to care. I think NPs deliver a different style of care. Because let's face it, we are nurses by trade, right? And so we have a different way of managing patients, and I think some patients notice that. I think they recognize that very quickly. I think because there are more of us willing to take on that role. I mean, I know 20 years ago, you know, physicians didn't really welcome NPs as much, and some of them still don't. You know, you run into that same old, I think, mentality of, well, you're still just a nurse. But, you know, as things have progressed and people are getting out of primary care medicine, I think there's going to be a higher level of dependence on NPs, especially in the primary care world. I think they make big practice groups who rely on them heavily. I think they take a lot of burden off of them. I think that we have the ability to probably do so much more than we are, and I think being able to advance that as, you know, this big surge of nurse practitioners are coming into the mark here. You know, I think there's a lot of advanced things I would like to see them do, or be able to do, or at least have access to do, because it's not going to be as easy to see a primary care physician anymore. And I think we have been successful in providing that extra care, and I think in some ways, some patients enjoy the advantage of having an NP versus an MD. Obviously, you know, I think there's a need for both, but I think there's a lot of ways that nurse practitioners, and even, you know, the physician assistant provider groups have really helped provide a specific population of patients with better access to care, and in some ways probably better care. But overall, I think their influence will continue. I think each geographic area of the country probably operate a little different under that. You know, the big cities have always tend to utilize NPs in a far better fashion than some of the smaller areas, and I'm sure that's in part because their facilities are larger. They're tertiary care centers, you know, they're big practices that are intertwined with huge teaching programs, and I think it just kind of in some ways lends itself that way. But you know, here in our area, a lot of what we do, we practice with inside, you know, closed critical care units. You don't see a lot of critical care NPs in this area because of that reason.
Yeah.
So, you know, I think that it could be a beneficial part of the future, especially someone like you with your background, being in the critical care, you know, it would be extremely advantageous to have you there on a around-the-clock shift in a closed unit type setting, the same way that you do some of the residents. And, you know, I think that's hopefully what they will design that to look like later down the road. Not eliminating, obviously, we can never eliminate an intensivist position in there, but just having better hands-on ability to do that. I think it would increase patient care tremendously, and, you know, anytime you have access to someone with good medical knowledge, and you're always gonna have a more favorable outcome.
Absolutely. What do you think are some of the barriers that APRNs face?
I think some of the physician groups were not pleased at the scope of practice that we were allowed. I think they are still not. I think some of the barriers specifically are, we don't have a consensus in terms of a state-to-state ability. So, you know, Florida, for one, has always been a little behind the 8 ball with APRN practice. You know, and if you take all the subspecialties out and you include all the advanced providers from midwifery to, you know, CRNAs, family practitioners, acute care practitioners, everybody's treated a little bit differently. CRNAs, I think, are just now, well, I know Michigan has started to allocate them the ability to practice outside of having an anesthesiologist overseeing them, and which, you know, that's a big thing. Here we don't have that option yet, and in Florida there's even less options, and I think that's always been, I think, a little harder to you know, come up with this mass ability for all advanced practice providers to stick together and say, hey, this is where our scope of practice lies, and we want to be able to practice within that scope without getting shot down at every turn. Or, you know, if my husband moves to Florida and we have to move our family to Florida, and now my practice abilities are limited because I'm in a new state. And I think that's always been a barrier. I don't know the best way to get that eliminated, but I think people still think that, nurse practitioners need to be followed around by a doc, and that's actually not the truth. So, I think that will be a barrier that's a little harder to hurdle. I even hear it now walking around the hospital, where so-and-so has to sign off their note. Well, no, they actually don't. They're permitted to do that. Do they have to agree with them? Or, yeah, sure, but I don't know how quickly that's gonna change. I mean, it's been 10 years, and I still see some of those things. I still hear some of the things. I think areas that are utilizing more practitioners probably have that thorough feet a little easier, and to have primary cares coming and adjust to that. But in some of the areas where you have older independent practitioners that have been doing this for years, it's really hard to break down that wall. And some of them still are not happy about you being here, and I don't know that barrier will ever completely go away, and it may not. Hopefully they learn to play a little nicer in the sandbox, or at least if they could recognize the advantage that they would have by having a practitioner available. But medicine has changed so much in general, even from the practitioner side. They have to see more patients, their reimbursement is less, the time spent with people is less. So I think any additional healthcare provider that you can add into that mix would make a huge benefit. But like I said, I don't think we'll eliminate that physician nurse practitioner completely, and it may never, but I would like to see there be a little more consistency across the states in terms of scope of practice, the independence of practice, who can oversee and what laws surround that. There's a lot of stipulations. DEA, requires you to be under someone. You can't over prescribe something that your preceptor or your answering physician can't prescribe, even though you may be able to, but if they can't, then you can't. So I would like to see some of those things kind of find their way out of our barrier, but until that happens, I guess, we just be grateful that we can do anything.
Right. What other changes would you like to see made for the APRN?
Well, I think from a clinical standpoint versus an academic standpoint, I think a lot of people shy away from going into NP because, if you're looking to get an advanced degree in some capacity, it's obviously financially easier to get an MBA. You have a quarter of the hours. I think I am happier now that they've made it a little easier for non-traditional people to go back to get these advanced degrees. And I think before that was a huge barrier. I'm not sure how I feel about having newer grads go directly without significant background in something, some sort of medical emergency medicines with some sort of ability to do that. But I would like to see there be parity between PAs and NPs in terms of valued of pay. So I guess I just put the same stipulation that physicians put on us. But the truth is, some of them are at a much higher starting pay scale as a PA, and they have very different backgrounds. You could have a business degree and get go back and get your PA license, and then all of a sudden, I'm thinking, are you kidding me?
Right.
Do you know what we did for the last 2 years to get this? But so I do think across the board that's become better, and I think they've done better with that. But I think, at least in my day, it was tough. There were hardly any programs that would allow me to work and be a single mom and get the clinical hours that I needed without jumping through fiery hoops to do all of those things. And, you know, I wasn't in a position to be able to not work.
Mhm.
It wasn't in the cards for me. I couldn't financially do it.
Right.
So, I think they've made that better. At least I feel like you guys have had a little better advantage. I mean, Lord knows I know how many hours you work, and
Yeah.
but that I think needs to continue to improve. I would like, again, for at least physicians to understand that, you know, we're not asking to have the same initial that they're having,
Mhm.
but we're asking to recognize us as being someone of clinical excellence and, you know, of that level that we can make decisions without feeling like
Yeah.
a second-rate citizen or, you know, wearing the doctor's stethoscope sort of thing. But I think, you know, like every field, I think they'll make advancements. I think things will get better. I think some of the people see the value. Patients certainly see the value. I mean,
Right.
we hear it all the time. And, you know, I hear it from just being, you know, when I'm out in the community supervising and hearing them say, oh, I see, you know, the NP who's this and she's wonderful. She
Mhm.
listens and,
Right.
you know, she answers all of our questions. She goes the extra mile. And I think, again, that comes back to the fact that we're still nurses.
Mhm.
We're trained differently. We think differently. We feel differently. And I think those are all really, really good advantages. And I think part of that, adding to advancing our education and our level of knowledge and our skill sets, I mean, I think it makes a pretty good package. I mean, I think we're trained better. We see a lot of med students here. I have med students that follow me all the time, and I think, didn't y'all learn this? Like, what are y'all learning?
Yeah,
Like,
right.
there are days I'm like, really, what are you learning?
Uh-huh.
Because I feel like you should know this by now. Like,
Right.
what kind of classes are you having? And I know you can't teach a compassion class, but
Mhm.
I think the benefit of NPs coming from obviously a nursing background is that we are developed that way, you know, and I think it makes a big difference on the other side of what we do. And I think you can have significant impact because of that. So I just hope that the field continues to grow. I hope that smaller areas like our area doesn't oversaturate and people get frustrated. And again, you know, right now you see a lot of NPs are going back to the bedside and doing different things because the liability is less, you know.
Right.
Sometimes the stress is less, sometimes not. But I think, you know, some of those things have to change because we're going to create a lot of NPs that would be really, really good NPs, but they're not going to want to deal with that side of it, especially now that the travel nursing has hit in full force. You know, these kids are making crazy money, and it's not always about the money, but if you can go work 3 days and make the same money you're making as an NP and not pay for a DEA license and additional liability insurance and all of the things that go into that, and, you know, live your life on call 70 hours a week, or so I think we need to find a way to keep our NPs in a better life, and I think that will eliminate some of that burnout, some of the thought of why am I doing this when I can go do what I did for 20 years and make a lot more money and go home and not have the same headache.
Yeah.
So I feel like that's probably in every career thing, but I just worry now that we have so many that have kind of gone back to the bedside or to different roles that it could become a chronic problem. So hopefully they can find a way to understand that, you know, we may have to make some changes as a group and as a, you know, healthcare as a whole.
All right. Thank you.
You're welcome. Good luck.
Thank you much.